Welcome you all to this episode of Upgrade. Upgrade serves as a very good platform among doctors to share the knowledge and upgrade the knowledge. Today we have an important topic, a clinico-pathological crosstalk. This will be an interactive discussion on lymphoma workup between myself and Dr. Krishnakumar Rathnam sir. With this, I hand over to Aditi to introduce the speaker.
This is a very important topic from the clinician perspective. And instead of having it as a lecture from the oncologist or a lecture from the pathologist, Dr. Madhu and myself, we decided that we will have it as an interactive discussion. So that's why we have given the name Crosstalk. And this is how certain cases may have to be approached from the clinical as well as the pathological point of view for the right diagnosis. Because as we all know, in lymphoma, the accuracy in the diagnosis of lymphoma and its subtype is very, very important, not just from clinical, but also from the therapeutic point of view, as many lymphomas are highly curable and highly targetable. Even in advanced stages, people are living for many, many years. And how does this happen? This happens only if we have the right diagnosis in place. So pathology becomes an integral part of the medical oncology practice. So that's the reason we brought up. This would be, we would probably have the basics. So why is this topic important? Next, please. So as far as lymphoma is concerned, we always teach our postgraduates that it had various nomenclatures and names, and till some time even pathologists did not have a concurrence on what to call various types of lymphomas. So initially they were calling it lymphosarcoma because of the morphology. Then they found a lot of reticulocytosis and reticuloendotheliosis early 1923 and 24. And then there was some metamorphosis and it was called as reticulum cell sarcoma. And then somewhere between 1830 to 62, the famous story behind the diagnosis, and I mean, should not say diagnosis, it was the discovery of Hodgkin lymphoma. And since that particular time, probably pathologists have been able to figure out that there are two types of lymphomas, one called the non-Hodgkin and the other called Hodgkin. Next slide. And obviously so, this is because each of these lymphomas have different treatments and different outcomes. Next slide. So you can just go down. So Hodgkin lymphoma had its evolution in classification using Rice classification, Luke's classification, Jackson-Parker. Similarly, non-Hodgkin lymphoma was characterized by wonderful pathologists from time in history. The earliest had the Robin-Smith classification, Gall and Mallory, and Keel classification. All these were done predominantly based on the morphology and to some extent the clinical correlation. Next, please. And as this morphology was evolving, the cellular ontogeny, the lymphoid and the myeloid series, and the lymphoid further being classified as T cells and B cells, and the B cells which go through the germinal center and mature to form plasma cells. All these were being well characterized. And next, please. Lymphomas started getting classified into one of these cell lineages using what is called as immunohistochemistry. So I'm sure that Madhu will be talking more about this, but for the postgraduates and the other doctors who are practicing, based on immunofluorescence and indirect immunohistochemistry, two methods, they are able to label the monoclonal antibodies with certain chromes so that it can identify certain specific cell markers. And these surface markers are like identity badges on uniforms of cells. And based on these identity badges, they will be able to classify the cells as T cell, B cell, and which stage of maturation in the cellular ontogeny this particular cell is being identified as. And based on this, today's world, next please, we classify the lymphoma into so many types as B cell and T cell, and based on the level of maturation using the surface expression of various markers using immunohistochemistry, we have a huge classification of lymphomas. Next, please. So in the 18th century, we just started with a common terminology like lymphosarcoma, lymphoepithelioma, and various other gross terminologies. But today, this is how lymphomas are classified, and it is still evolving. Next, please. So as far as the clinician is concerned, I already told you that lymphoma is very important from the clinician perspective because many of them are curable. But in the proper oncological coordination in diagnosis of the oncologist coordination with the pathologist for diagnosis is mainly because more than the right diagnosis, sometimes it can help in avoiding a wrong diagnosis. Next, please. So I am just running through a couple of case reports, case studies to explain better where the clinico-pathological coordination can improve outcomes in patient care. So case one, this is a 16-year-old, this I should say was a 16-year-old girl presented with low-grade fever and weight loss and a matted nodal mass in the cervical region. Chest X-ray was normal. Ultrasound abdomen also showed few para-aortic lymphadenopathy and hepatosplenomegaly. And the cervical adenopathy, FNAC, was done in the local hospital, which revealed a pleomorphic inflammatory infiltrate with a lot of epithelioid cells and giant cells. And her ESR was high, and her MANTO was also weak positive. So obviously, for a practicing, physician in the Indian scenario, this is very common. This would be diagnosed as a TB lymphadenitis. So this patient was started on antituberculous treatment for 3 months. However, the quick weight gain was not seen, and the fever which appeared to have gone after initiation of treatment seemed to be relapsing very soon, and in about 3.5 months, the nodes started increasing in size. Next, please. So here I have the first few questions to our head of the pathology department, Dr. Madhu. Dr. Madhu, how do you diagnose a tuberculous lymphadenitis generally? And as a pathologist, where will you be comfortable? And where do you find the utility of TB PCR in the nodal tissue? Because nowadays, you know that many of the practicing physicians ask for PCR as they dispose a request form for histopathology suspecting TB lymphadenitis. And how is this TB gene expert, which seems to be gaining popularity, different from the routine TB PCR?
Has been taught throughout our MBBS life and throughout our postgraduate and super specialty life. And this is the answer for a tuberculosis diagnosis in histopathology. The classical description is granulomatous inflammation with central caseation necrosis, and there can be Langhans type giant cells within the granulomas, and these are usually surrounded by lymphocytes, that big cuffing of lymphocytes, small lymphocytes around it. But this is a very classical description when we say this. Whether this can occur in other diseases or can tuberculosis present without this, both these are possible. For example, even in this picture, this is a classical tuberculous granulomas, but if you see, there are these granulomas are also there. There is no caseation here. Even Langhans is not here. Langhans giant cell is not here. So now the tuberculous granulomas have been associated with the kind of immunity the patient is having. And at the same time, the same caseating necrosis granulomas can also be seen in not only in tuberculosis, can be in fungal, can be in atypical bacteria or a leprosy. So what is more important is in the particular setting for most part of the time, let us say 90 to 95% of the time, when a classical description is there and we see a classical granulomatous inflammation with caseation necrosis and acid fast bacilli in the node, typically showing a rod-shaped bacilli, then the diagnosis is almost confirmed. We don't even suggest, we straight away give this as tuberculosis. There's no issue with that. When we have this, seen this as a first bacilli in a typical setting. But the problem with the acid first bacilli is that in almost all the literature, it is seen in only 20 to 30% of the histopathology samples. So coming to the next question, that is where the tuberculosis PCR is very important, and it can increase the sensitivity. So when we have a 20% sensitivity in the AFB special stain, this TB PCR can increase the sensitivity to 43.33%, and more importantly, it is 100% specific. When I say acid fast bacilli, it doesn't mean always mean tuberculosis. There are also others, acid fast bacilli are there. But in a setting, what we regularly see, we call them as tuberculosis. But with PCR, there is no other second thought because these sequences, IS6110 sequences, which we use for TB PCR, have very specific area in tuberculous bacilli, and the specificity is quite high. So moving to gene expert, the third question, it is a very similar to TB PCR, but there are several advantages. It is a cartridge-based real-time PCR. Unlike when we say PCR, there are different ways of interpreting it. We simply run a PCR polymerase chain reaction and take out the product, run in a gel electrophoresis, we see the band. That is a simple PCR. Whereas in real-time PCR, while running by the number of cycles the PCR has run, the machine will be able to give a diagnosis. At what cycle the bacterial sequences have been amplified. So that is the major advantage. It is a very short process. The entire test takes only 2 hours. But all is good. The problem is in FFP, formalin fixed paraffin embedded tissue. So that is where the lymph node assessment problem in histopathology. But when you see gene expert for any other sample, for example, sputum or pleural fluid or a bronchoalveolar lavage, the sensitivity will be quite high, 98% or 99%. But for formalin fixed tissues, the sensitivity is low because the formalin causes cross-linking of proteins and it fixes the tissue, and a process is required before giving it to the gene expert. This usually means an enzyme with which it is incubated for overnight. So that process is required, and that is where the difficulty is. This can be overcome by if the clinicians or the surgeon plans it prior, because gene expert works wonderfully in fresh specimens. So if you're planning for a node, if you're planning for an FNAC, just aspirate. If you're planning for if you're strongly suspecting tuberculosis, just send that material, fresh material for TB PCR or gene expert as well. The results will be immediate. But once it is processed with the formalin and paraffin embedded, the retrieval of these sequences from the material falls. That is why the sensitivity with FFP is 53.2%, while with the fresh material like sputum or bronchial lavage, it's quite high, 98-99%. The another best advantage is that it also is a in the same run you can also diagnose the rifampicin sensitivity This is actually a multiplexed real-time flow cytometry that is encased within a cartridge. So everything is there. There is a positive control, negative control. The chances of failure of the test is very less. So that is the biggest advantage of Gene Expert. What do you say?
Yeah, so probably we can conclude that if you have a tuberculous lymphadenitis paraffin block, suspected tuberculous lymphadenitis paraffin block, I can ask you for a PCR. Suppose if you have a physician who comes to you with either a pleural effusion or a pericardial effusion and they are not very sure, and they quickly want to also screen PCR for tuberculosis, these fresh tissues and the fresh aspirates can be sent for Gene Expert. Is it correct, Madhu?
Yes, yes, very much.
Okay, so the next slide as we move on. So you already answered the question that FNAC of the node is enough sometimes for tuberculosis if you're able to find AFB. But if at all you want a biopsy, would you like a true cut biopsy or an intact node? And which are the common nodes which you think should be avoided by the surgeon for biopsy to avoid false negativity?
Okay. So the first part of the question, whether FNAC is good enough. Yes, FNAC, going by literature, has a very high sensitivity up to 77.5 to 75% for either non-Hodgkin's lymphoma or lymphoma, going by FNAC standards. But with the excision biopsy, it's almost like 100%. You have a material there in your hand. The problem with Hodgkin's lymphoma is further amplified by the fact that the Hodgkin's cells constitute just 1% of the tumor. It is not going to be there everywhere, unlike non-Hodgkin's lymphoma. So pretty difficult if the aspirate is of low cellularity. That's why the appropriately done FNAC. That's why the word has been put there. So if the cellularity is less, or the lymph node, let us say it is partially effaced, and that is the node we have chosen for FNAC, those are the confounding factors which will impact the diagnosis of Hodgkin's lymphoma in a FNAC. So we always, whenever there is a malignancy, it is preferable for to go for a biopsy for definite diagnosis. It not only helps to study the architecture, because in FNAC you don't see the architecture of the node where the cell is. But suppose if the Hodgkin's is considered, the architectural pattern in a lymph node will say it is involving the paracortical or interfollicular region, whereas FNAC will say nothing. So even for that, or if you have to confirm it or have a differential diagnosis with the other tumors that needs to be worked up with immunohistochemistry, a definite lymph node biopsy is must. So coming to the second question, whether cervical lymph node or inguinal lymph node, it's a straightforward, simple answer is cervical lymph node when both are involved. And going even by literature, Hodgkin's lymphoma at most 75% of the times involves the cervical lymph nodes or central group of lymph nodes. Inguinal lymph nodes is the last one to be considered for that matter. Even the axillary lymph nodes, better to avoid it. If there is no other goal, let us say cervical lymph node is just 1 or 1.5% is soft, whereas a lymph node in inguinal or axillary region is 3 centimeter hard, then the equations change. Then we prefer a hard, large lymph node biopsy. That's where the difference is. Otherwise, 70 to 80% of the times, if everything goes well, cervical lymph node is the most preferred state. And going to the third question, already I answered this. The most important thing is the architecture when we see the entire lymph node. In true cut biopsy, again, the problem is we don't get the entire architecture, especially when an enlarged lymph node where more than half of the lymph node architecture is distorted by a tumor or other half is preserved. So you don't get to see the entire architecture of the lymph node. When I mean by architecture of the lymph node, this is what this picture is what I mean. So there's a capsule here. So there's a marginal sinus. This is where we see the metastatic carcinomas, that is the initial areas to spread. and this is a cortex. Cortex with the germinal centers. This is the area where we have to see for follicular lymphomas, and this is a mantle zone. This is the area where we have to see for mantle cell lymphomas and paracortex or interfollicular zones where we have to see for Hodgkin's and other viral diseases. So this advantage for a pathologist is lost when we don't get the entire biopsy. But moving to the current scenario, I think the world is moving towards true-cut biopsy much more, as we see in the northern states and the western countries. It, in a way that the immunohistochemistry has developed to that extent that all these cells can be identified in a true-cut biopsy. So moving towards that scenario, we have to adjust with that, but it will take some time for us to understand what these cells are. But still, my preference will be for intact node biopsy.
Next slide, please. So I think Madhu.
Sir, your mic is on.
Yeah, sorry. So you told me about the how IHC is going to add value, especially you said with today's IHC, with just true-cut biopsy, you may be able to delineate the exact lineage of cells. That was a take-home point, especially in patients who are coming with mediastinal nodal mass, or they are coming with lung mass, where you may not be able to get a clear full intact tissue. You will be able to use IHC to differentiate these tumors. So, Madhu, can you just tell us very basically in few words, what is monoclonality? Because it is very important for cancer. Not all nodes are cancerous nodes. So what is monoclonality, which is the basic definition for cancer?
So regarding the first question regarding immunohistochemistry, I said immunohistochemistry. If you have a classical morphology, then why immunohistochemistry? Even with WHO 2016, the Blue Book for Pathologists, Hematolymphoid, there are some certain differential diagnoses even for a classical Hodgkin's lymphoma. So that include nodular lymphocyte predominant Hodgkin's lymphoma, NLPHL. That's a totally different category. When we saw the 2016 classification, we saw it's still a Hodgkin's, but NLPHL is a different category which deserves a different kind of treatment rather than a classical Hodgkin's lymphoma. And the picture can be mimicked in T cell histiocyte-rich large B cell lymphomas, as well as in ALK positive or ALK negative ALCs. So these are differential diagnosis, because, as I said, there is also differential diagnosis for pathologists. A classical picture, a classical clinical setting, I'll come to the morphology in the next slide. That won't be an issue. But when things go slightly wrong, because there are always, we don't see a classical Hodgkin's lymphoma cell in every case. So that is where we require immunohistochemistry, and that differential diagnosis has to be considered. So what we use is this equipment, I6000 Biogenics, and what I mean by immunohistochemistry is a primary antibody, let us say CD45, a common, all the hematological cells will be positive, or a CD20, where a B cell can be positive, all the B cells, a pan B cell, or let's say Paxpi, all these cells. All these are antibodies which define a cell lineage. So when these cells are tagged with a primary antibody like this, and if it has directly a tag here, like immunofluorescence, we call it as direct immunofluorescence, as one of the slides by Sir said. But in immunohistochemistry, there is a secondary antibody which is attached to a enzyme. That is why the chemistry is here. So it is an enzyme reaction. That is why the chemistry is. So this is a substrate which reacts with this enzyme and gives a color product. What we regularly use is a DAB. So this usually produces what in our setting we use brown color. The DAB is. There are several colors which are there. So that is shortly about immunohistochemistry, how the method works. Now coming to morphology, we all know the Hodgkin cell, classical Reed-Steinberg Hodgkin cell. That's the owl eye appearance. It's a large cell, 45 micrometers diameter, classical binucleate or bilobed cell, central nucleus, and a large nucleolus surrounded by a halo. But the problem is, it's not these cells alone. There are cells which are defined like mononuclear cells. It's not going to be present in all the Hodgkin's lymphoma. There are variants. In mixed cellularity, yes. Mixed cellularity, when I say mixed cellularity Hodgkin's, we have a pleomorphic population in the background, eosinophils, neutrophils, lymphocytes, plasma cells, and there are these tumor cells, classical Hodgkin cells. This no problem. We have a straightaway diagnosis. But when it comes to nodular sclerosis, we have a variant, a lacunar cell, where it's a mononuclear cell with perinuclear clearing or halo. It's not going to be the same. Again, mummified cells or an LP cell in an NLPHL. All these are again Hodgkin cells, but they will have a different background and they are also in the family of Hodgkin's. So that is why we need an immunohistochemistry. Not only to confirm that this is Hodgkin's and this is going to respond to this chemotherapy, it is also necessary to rule out other lymphomas, NLPHR, ALK, or even T-cell rich B-cell lymphoma, to some extent DLBCL, especially in the gray zone lymphomas, mediastinum. We will come to that later. So the classical Hodgkin's lymphoma panel includes all this. We sometimes play with this to some extent, because sometimes when we see rich histiocytes, we may include to rule out the histiocytes which are there. For example, T-cell B-cell lymphomas also will have many histiocytes. And EMA, when we have a strong suspicion that there will be ALK, then we need a second marker. And CD21 again in NLPHL will help in the follicular dendritic remnant also, and EBV. Certain types like lymphocyte depleted variants or an nodular sclerosis variant can be positive. But these are supportive. The most important marker which we heavily depend on is CD30. CD30 positivity, a typical Hodgkin cell which is CD30 positivity, or even it may show a Golgi positivity. One of the cells with Golgi apparatus may show a very strong positivity. And then CD15. The problem with CD15 is 30% of the Hodgkin's lymphoma cells can be negative for CD15. So we take it with a pinch of salt. If it comes positive, yeah, well and good. It is positive. It's a straightforward Hodgkin's. But when it comes negative, then we have to rule out the others with very carefully. Then we look at the PAX5 one. PAX5 is a B cell marker. These Hodgkin cells are germinal center derived cells. So these are it has been proven with the immunoglobulin chain assays. The sequences have been there. With that, these cells have been proven that these belongs to germinal center B cells. But the problem is these germinal center B cells lose many markers as they transform into a Hodgkin cell. The prominent ones are the CD45. That's why the CD45 is always lost in Hodgkin's, even CD20. CD20 is going to be lost in majority of the Hodgkin's. It's hardly 5-10% of the Hodgkin's will be positive, but still it will be positive. It can be positive. CD20 positivity doesn't completely rule out a Hodgkin's, but CD45 is most every time it is lost. Then ALK should be negative. Obviously, ALK positive should turn your diagnosis to ALCL. Especially, we have to also see that PAX5 is negative in those cells because those are T cells. And then CD3, especially for the background cells. So invariably, these background cells are all T cell, predominantly T cells. Whereas in NLPHL, that will give a clue again. NLPHL, those will also always be B cells, and those large cells will be 20 positive, and the small cells will also be 20 positive. So these are the differentials we consider with this entire panel, and we work it out with each of these markers. It is not just CD30 is positive, okay, fine. It doesn't just like that goes away like that. Because ALK positivity in CD30 positive cells entirely changes the equation to some other diagnosis. So we have to look at a panel. That's why we always recommend a panel, and we rule out the other diagnosis and come to a conclusion that this is a Hodgkin's lymphoma. Regarding monoclonality, so monoclonality in neoplasm, in tumor, very specifically saying this because there are various other areas where this monoclonality is used. A single aberrant cell which has undergone carcinogenesis reproduces itself into a big cancerous mass. This is the simple explanation of monoclonality. This is very easy to see and find in cancers like adenocarcinomas, let's say a colon or breast carcinomas, because most of the times if it is CK20 positive, your B cell is going to be CK20 positive, and ER is positive, it's all on phenomena, it's ER positive, that's it. But when it comes to lymphocytes, we have large number of lymphocytes. Even by ontogeny, we saw there are many number of lymphocytes. So to establish a clonal pattern is going to take much more technical analysis than we normally what we do. So that is why I took an example of T cell. It need not be T cell, even a plasma cell. For a simple diagnosis, a plasma cell. So plasma cells, either it is going to be kappa positive or kappa negative. Let us leave the non-secretory part of plasma cell myelomas. So if either of this chain is present, then we take that as only kappa is present, lambda is completely absent. So then kappa chain restricted clonal plasma cells, that is abnormal. Similarly, more abnormal is the lambda positive cells, because lambda positive even it's almost lambda positive large quantity of plasma cells almost suggests it is going for a neoplastic process. Again, it also comes with other other parameters like you can see the light chain assays in biochemistry labs or benzoprotein, whatever the additional requirements that is required for myeloma. For B cells and T cells especially, it is very difficult. CD4A to some extent can define monoclonality, but the ultimate thing is this TCR BDJ rearrangements. So that is the final expression pattern of the T cells. Once that is defined in a lymphoma, you can know that is where the MRD also is very helpful. But right now we are restricted greatly because of the difficulties in analyzing those with PCR and the kind of background cells that can also take up. Expertise is needed. So right now we are restricting ourselves with either double negative, double positive, CD4 positive or CD8 positive cells for T cell lymphomas. Similarly, for B cell lymphomas, again, mature B cell lymphomas, kappa lambda is again a useful thing. Again, immunoglobulin rearrangement assays are there, but more specifically for, let us say, MRD, measurable residual disease. Now, minimally residual disease was previously, now it is a measurable residual disease. We assess clonality by taking 2 or 3 markers which are present in a single cluster of cells. So once, let's say for acute leukemia, 19, 10 or 20, 10 should not be positive at the same time. That's abnormal cell. So if those kind of cells are in a cluster, then we take this as clonal cells. So in lymphomas, that in hematological malignancies, it requires much more workup and due diligence.
Yeah, so Madhu, we can take back the message that if a doctor has a suspicious lymphoma, he should take an intact node biopsy if possible, send it to a pathology lab, and even if tuberculosis is suspected, it is better to confirm with immunohistochemistry if there is a strong suspicion that it could be lymphoma. And sometimes, if we are unable to establish the lineage or try to get the exact parent cell, we may be able to use higher techniques to determine clonality like PCR. So that was a good point from you, Madhu. So this patient, next slide please, was referred to us for further management, and when the biopsy was done instead of the FNAC, it turned out as, next please, Hodgkin lymphoma, which was confirmed with immunohistochemistry. Next please. And this patient definitely did pose challenges for the pathologist as well as clinician. Next please. So there are different kinds of Hodgkin lymphomas can mimic or can be mimicked by other non-Hodgkin and Hodgkin and varieties like Hodgkin. So ultimately it is going to be the immunohistochemistry which will carry the right message for the clinician to start treatment. Next, please. Next, please. And I will just, I think we will skip these questions. I will just put you one question to you, Madhu. I think you can directly go to the second question because you just discussed this in the previous slide. Would you like a frozen section for diagnosis of lymphoma, or are there challenges?
I would never prefer frozen section. This is my personal opinion. For the facts that for the facts that we are doing frozen sections for other tumors. So let's say, for example, carcinoma cells. We don't have to worry much. That either it's going to be fully involved, or at the most it has to be in the subcapsular sinuses, and those are large cells. And I don't have to worry about lymphocyte confusing with those cells, how the pattern is, what is the background is, nothing. It's going to be sheets, glands, whatever it is, it's going to be there straightforward. But for hematolymphoid malignancies, we don't prefer frozen sections. For two reasons: this sample can be very precious if it is a lymph node which we are going to take out, and that's the only node available for some reason in the periphery, maybe the central nodes may be there, and we need that architecture to define, to work up what the lymphoma is about. So once we freeze the tissue and thought back, this architectural changes will greatly affect the routine histopathology. So the same tissue usage in routine histopathology becomes difficult, and frozen as such is not a very definite diagnostic instrument. It gives on-table decision-making diagnosis in certain conditions. It will never replace a routine diagnostic modality.
Yeah. So that point is well taken. So this was again, I sorry to just come in. So this was for the benefit of our postgraduates. I can see some of our PGs are logged in. The frozen section, for those who are not very sure what it is something like a real-time screening by the pathologist in the theater, operation theater. So let us say that if somebody is removing a tumor specimen, and they, before closing up the procedure, they want to make sure that cells are there. There is a very quick way of freezing the tissue to subnormal temperatures and immediately subjecting it to processing, and the pathologist tells the surgeon whether adequate tissue is there or not, or whether the margins are involved by tumor or not, and certain details like this. And based on this, the surgeon takes a confirmation to close the case. So what Dr. Madhu has been trying to say is, in lymphoma, since the architecture is very important, and there could be artifacts and may also affect future immunohistochemistry processing in a frozen sample. Plus, the sample itself may be very precious and in small quantity. If we waste it for frozen section, we may not have adequate tissue for running other IHC markers. So that is the reason Dr. Madhu has mentioned that in a lymphoma, frozen has its own limitations. Thanks, Madhu. Next slide, can we move? So this patient actually finally was treated for Hodgkin lymphoma, received a consolidation radiotherapy, and today, maybe it's about 16 years now, this girl is an MBA and she is working in London. This was a real-time case. Next, please. In want of time, we will go a little faster because I think the first case was taken in detail, because this case enumerates why Dr. Madhu is very particular about morphology, about the type of node, about the intact node being given, and why IHC is important for diagnosis of lymphoma. So we did go a bit slow. So we have a quick 3 more cases, and then I think we have about 25 minutes. So we will just 20 minutes, and we will just rush through this case. So this is a 14-year-old boy who came with acute dyspnea, and he had a large left side pleural effusion with mediastinal nodes, no peripheral nodes for biopsy. So that was a big limitation. This boy presented to the casualty, MMHR casualty, and a pleural fluid cytology revealed lymphocytosis, but the only clue that few lymphocytes were looking blastoid. So I can understand the pathologist cannot give more information, but they said there are some cells which are looking blastoid in the pleural fluid. Next, please. And this patient obviously was unfit for a mediastinal node biopsy. Repeat pleural fluid cytology was done, and once again, it was not conclusive. So, considering the young age and some blastoid cells in the blastoid cells in the pleural fluid, we suspected there could be a lymphoproliferative disorder like leukemia and leukemic disorder, and a bone marrow was done which showed 21% blast. And finally, there was a flow cytometry done on both the bone marrow as well as the pleural fluid, which was revealing T cell ALL. So this patient with a large mediastinal mass and pleural effusion, no node for biopsy, was diagnosed as a leukemia using another technique which was neither biopsy of the node nor immunohistochemistry of the node, but another test which is called as flow cytometry. Next, please. So, Madhu, can you just very quickly and briefly explain what is this flow cytometry and how this is different, and what are you doing in your lab? Because I think you're the only one doing flow cytometry in Madurai and South District, so you must be getting a good number of samples. And other than just lymphoma diagnosis, where else do you use flow cytometry in our lab?
Yes, sir. So flow cytometry, as the name implies, it's a measurement, measuring properties of the cell as they flow, as cells flow in a fluid suspension across an illuminated light path. So what we mean is that we send the cells in a single file manner through a fluid tube. This is the sheet fluid, and we send a laser beam and we collect the light. So we see how the cell looks like. So this is a simple flow cytometer. It is there everywhere in the even in the blood counters. Now modern day blood counters have this thing. But when it comes to immunophenotyping, like acute leukemias, thing is slightly more updated, or it's more complicated slightly. So what we do is very similar to immunohistochemistry. So like Sir said in the previous slides, you have a primary antibody under that is tagged to a fluorescent material. Same way, it is tagged, the antibody, primary antibody is, let's say in this CD45, it's tagged to a fluorescent material, and it is mixed with the cell so that this CD45 sits on any of these cells that those have the receptors. Almost all the cells will have it. So, and then it is subjected to flow cytometer principle, and the light is collected and it is plotted in a scatter plot. So depending on the intensity, these cells normally occur in the peripheral blood, and this is an abnormal population, what we call as the blast gate. So that is the starting point of analyzing the peripheral blood. So now we can play with a lot of other primary antibodies that can be tagged with almost like 8, nowadays 16 colors are available. 16 fluorescent colors are available that can be tagged with these different antibodies, and each cell can be studied for each of these markers. So to put it in a very limited way, acute myeloid leukemias, the defining marker is MPO, cytoplasmic MPO. In T cells, it is the cytoplasmic CD3. Surface CD3 will help, but immature cells will not have surface CD3. And for B cells, two of these markers should be present: 79A, 22, 90, 10. So TDT and CD34 are immature markers. These are additional markers. Let's leave them for the out of the scope of this talk. So this is a simple example of how the light is collected and scattered into a plot. So all this APC and PE, FITC are the fluorescent tags. Leave the colors. The colors can be changed into any color, but the machine has picked up CD7 positive cells in this. So these are positive for CD7. CD7 is a very good marker for T cells. And this is the surface CD3. So surface CD3 is negative, but cytoplasmic CD3 is positive. So these cells are a clonal, single population of clonal cells that are positive for cytoplasmic CD3, but it has not gone to that extent of developing a surface CD3. So it has got arrested somewhere in between, and from there some mutagenesis has occurred, carcinogenesis has occurred, and then it has started going as a cancer. That's what it means. So cytoplasmic CD3 positive, surface CD3 negative, and another one more marker 7 is positive. So now coming to 4-8 again, we have these cells. See, the T cells mature in a way double negative, double positive, and lose one of the markers CD4 and 8. So this is almost to that extent, it is entirely CD8 positive. So this cannot happen in a normal body. So usually it will be there will be a ratio between CD4 and 8, almost 1:1 ratio. So this again proves this is a clonal population of T cells, and for immaturity, cytoplasmic CD3 positive, surface CD3 negative means it is immature. Again, coming to TDT, it is an immaturity marker again. So that is positive. CD45 is dim, and the CD1A again a T cell marker which is positive. So all this concludes that this is a T cell lymphoblastic leukemia or lymphoma depending on where the site is involved. So other markers, other uses, what we currently use in our lab is lymphocyte subset analysis of simple CD4, CD8 and CD20 analysis, especially for rituximab therapies where this has been a norm nowadays, especially in transplant setups. Primary immune deficiency disorders in children, again depends on the T cells, NK cells and B cells. CD34 enumeration, especially in transplant setup, to exactly derive the dosage of stem cells to be given to the patient, and measurable residual disease in post-infection setup after giving the for mostly 28 days. So HLA B27, PNH, paroxysmal nocturnal leukorrhea, these things can be done. It's in pipeline and we'll develop it very soon.
Yeah, thank you, Madhu. So this case finally was a TALL. It has nothing to do with the lymphoma, and you can see by the end of induction, the pleural fluid has completely cleared and the mediastinal mass has also cleared and looks like almost like a normal chest X-ray. So this is where the right choice of test and an extended way of thinking or a lateral way of thinking can get quick diagnosis in difficult cases of lymphoproliferative disorder. Next slide, please. We will quickly go to the last two cases. So we had discussed about lymphoma. We also discussed about the role of immunohistochemistry, what node to biopsy, intact node to biopsy, what's the role of immunohistochemistry, how to establish clonality. These were discussed from the first case. And in the second case, Dr. Madhu also showed the graphs from the flow cytometry, how to diagnose cells in the fluid medium, especially leukemia, and that will help in treating many hematological as well as immunological disorders. So this is a third case, started off with a diagnosis of NHL, diffuse large B-cell lymphoma. So obviously IHC was a limited IHC was done outside, and this patient was started on standard R-CHOP regimen. R stands for rituximab and CHOP is the standard chemotherapy regimen. And he was relapsing quickly in between cycles, and then he came for further management. Next, please. So these patients used to quickly respond, but even before the next cycle was started, will start relapsing. Next, please. And when this patient was reviewed and the immunohistochemistry done, there were some abnormal markers and extra additional expressions and probable mutations were there in this subtype of diffuse large B-cell lymphoma, which was making the disease very aggressive. That is with a Ki67, which is a proliferative index of 80%, telling us that this lymphoma is absolutely aggressive. So that was explaining why this patient was relapsing in between cycles. Next, please. And Dr. Madhu, very quickly, because we are running out of time, are there any other additional tests like molecular tests beyond your immunohistochemistry for classifying these kind of lymphomas? And what are double hit lymphomas?
We'll go through this really fast. So beyond the IHC, there are tests available. Fluorescent in situ hybridization is the one which is the most. So fish fluorescent in situ hybridization is one of the most important techniques because it has a very short turnaround time. Next is PCR and conventional cytogenetics. So this is shortly the fish protocol where the DNA probes, complementary probes of DNA is denatured and hybridized to the testing cell, and then it is looked into the fluorescent microscope to look for this DNA probes, which are tagged with again fluorescent dyes. So these are the specific chromosomal translocations, oncogenes or tumor suppressor gene that are implicated in these lymphomas. So the most important one being the bucket lymphoma, celiac, follicular lymphoma, decoordinating translocation, BCL2, diffuse large B-cell lymphomas, BCL6. Now, the next question was regarding double hit lymphomas. So classically, double hit lymphomas means the MYC rearrangement along with BCL2 most of the times, and or BCL6 rearrangements. This is called as double hit when either of these are present. When all the three are present, is called a triple hit lymphomas. So we'll skip the immunophenotyping of these cells. This is supposed to be the screening procedure before fish. So when this occurred is because of this study which came up in 2010. So when they were looking at the DLBCLs, they found that almost 12% of them are not performing well, and they were having these translocations. This is a double hit or a triple hit translocations. So there is a category in 2008 WHO, the previous edition of WHO, where some gray zone lymphomas were put, like Burkitt-like lymphomas or large cell lymphomas, which cannot be categorized. When they were analyzed with these markers, they found that 50% of these large cell lymphomas are falling in this category. So now 2016 classification, this has found a separate topic in the 2016 WHO. So this is a intermediate cells with a typical starry sky pattern, and these are the intermediate cells with mitosis, high mitosis. But usually Burkitt lymphoma are negative for BCL2. The characteristic signature is CD10 positive, BCL2 negative. But BCL2 positivity means something is wrong with this diagnosis. So in this case, MYC rearrangement, a breakup probe was used, and when they are close, they will give this yellow signal. When this green and red, they are close normally, it should be. They give a yellow signal, but when they rearranged with some other gene, they give a separate signals. Like it depends on the probe what we are using. So this type of separating of red and green is abnormal. Again, BCL2 fish. Apart from that, this is also amplified. Multiple number of copies are present. Again, same with BCL6, when it should be very close to each other, it produces a yellow signal with red and green. But when it is rearranged, it produces a separate signal, green and loss. So that means that it's a double hit or triple hit lymphoma when 2 or 3 are present, but c-MYC rearrangement is very essential.
Thank you, Madhu. So this patient, as Dr. Madhu suggested, underwent the molecular testing for fish because there was some abnormality according to the immunohistochemistry, and as suspected, this came out as a double hit lymphoma. The regimen was changed to a different one, which is tailored for these kind of patients, which is called as a epoch rituximab regimen. It's a continuous infusion regimen, and then later this patient responded well and is now in complete response. Next, please. So the role of molecular pathology is also evolving, and we have to keep this in mind. So gone are the days where we were just able to be satisfied with lymphoma, then with non-Hodgkin or Hodgkin lymphoma, then with some immunohistochemistry, we evolved till recently, and now molecular diagnosis plays a very, very important role in accurate diagnosis of lymphomas. So this is the last case for today. I will quickly run through the case, and this was a patient with generalized lymphadenopathy with epitrochlear nodes and adenoid swelling, and biopsy outside was reported as query RS cells or query Hodgkin lymphoma because there were some bizarre giant cells. Next, please. And this patient was treated for Hodgkin lymphoma with standard regimen, but presented with extreme mucositis febrile neutropenia with a WBC count of 800, was in the ICU. In addition to that, he also had a chemo extravasation. Next, please. And this patient received very intensive supportive care. It kept us anxious with few points which are not fitting into our mind. That is this, if it is a routine Hodgkin lymphoma and the normal chemotherapy being given, why did he develop this much of neutropenia and this many complications? So a bone marrow study, unfortunately, was not done as a part of initial workup outside. So we repeated the bone marrow after the patient's counts completely recovered. We gave him 2-week time, and then the immunohistochemistry was done. And when we reviewed, there was more of a histiocytic infiltration of the bone marrow. We got the blocks from outside and got those also reviewed. Next, please. And when we did, I will come to the final what happened to this patient. So Madhu, I just have a very, very quick 2 questions for which we'll have a quick answer. Bone marrow biopsy, is it better than bone marrow aspiration? Because still now many physicians are not very comfortable with the bone marrow biopsy. So even for lymphoma, we have some patients who are being staged with only bone marrow aspiration. Will you be happy with the bone marrow aspiration only for staging lymphoma?
For staging, it is highly recommended a bilateral refined biopsy from both posterior superior iliac spine. Normally we do it on posterior iliac crest, the highest point, posterior superior iliac spine. The reason is these diseases are patchy. So it is not a diffuse process like acute leukemia. Acute leukemia, we don't even require a different biopsy. The aspiration, when it comes good, it is up to the bone marrow, the person who is doing bone marrow, whether to take a biopsy or not. Because it is a diffuse process, wherever the needle is put, the material is going to be there. For acute leukemias, that's the scenario. But for lymphomas, especially for staging, this is going to be a patchy disease, and it is mandatory to take bilateral refined biopsies of adequate length. This same applies for multiple myeloma as well, though it is now the scenario is changing, but still it holds good for any patchy disease. As far as the second.
So bone marrow biopsy definitely is mandatory, and at least a 1.5 centimeter length of the core bit is what is WHO recommended. Is that right, Madhu?
Yes, yes, sir.
Okay, thank you. Next slide. So actually the bone marrow aspiration needle itself is different from the bone marrow biopsy needle, which you're seeing on the right side. And once somebody starts doing a bone marrow biopsy routinely, they can find out and they can be comfortable in finishing both in one shot in most of the patients. Next, please. This block was reviewed, the node was reviewed, and this turned out to be a case of, next please. You can see CD1A negative cells, and you can see some amount of emperipolysis. Next, please. And this was at least not a Hodgkin lymphoma, and the final diagnosis was, next, sinus histiocytosis in this patient who had Rosai-Dorfman disease, and that was the diagnosis. So we stopped further chemotherapy for the patient and then switched him over to symptomatic. Till he was better, he was on symptomatic steroids, and then later the disease went into spontaneous remission after some time. Madhu, are there other conditions like Rosai-Dorfman which can mimic lymphoma and put you in trouble when you're diagnosing lymphoma?
Yes, for sure. Again, back to normal lymph node and lymph node architecture. but we will restrict this to Hodgkin's now. Now, Hodgkin's has very major mimickers in the form of rosoid augment, Kikuchi Fujimoto disease, SLE, both almost have the same morphology, but it will have necrosis, proliferation of cells, histiocytes, and there will be these crescentic histiocytes, which are very classical, that will give a clue. Otherwise, this will have necrosis, and there will be large immunoblasts, which can be confused with Hodgkin cells, and that too will be positive for CD30. Kimura disease, again, the background will be of polymorphic, like many eosinophils, and they may have very many histiocytes, but not really a B cell there. And viral inclusions, a typical CMV inclusion that resembles a RS cell, but it is actually a inclusion rather than the nucleolus of the cell. So again, infectious mononucleosis, CMV, EBV, these viral infections can mimic Hodgkin's. When it comes to non-Hodgkin's, it's altogether a different story. Like the follicular hyperplasia can mimic follicular lymphoma, depends on the architecture again. So immunohistochemistry comes handy in these cases.
If so, from these 4 case studies, it is quite clear that the diagnosis of Hodgkin lymphoma definitely needs a good clinico-pathological correlation. Second, the pathologist does not go only by the morphology, although the morphology is paramount important, forms the basis for diagnosis, but he needs to run through his complete panel of immunohistochemistry markers. A good clinico, I will say radiological as well as pathological approach would help in diagnosing lymphoma quite accurately, tailoring treatment accurately, as these are all curable conditions, and it is just not for diagnosis of the condition, but for also, from a doctor point of view, the main problem we are facing nowadays, it is medico-legal issues. And if we are not convinced with certain conditions, it's not wrong to get the biopsy blocks reviewed by our pathologists, get the immunohistochemistry done if it has not been done earlier, before embarking on any particular type of chemotherapy. Next, please. So with this, Dr. Madhu and I, Dr. Krishnakumar Rathnam, we are profoundly thankful to the upgrade team from Meenakshi Labs for putting us all together.
Good evening, everybody. This has come to the end of the session, and it was a very nice knowledge sharing sessions from one of the best oncologists and also one of the best pathologists. So now instead of calling it as a clinico-pathological talk, it was like a marriage between oncology and pathology. So how you can see how you can share the each other knowledge for the betterment of the patient care and healthcare delivery. So let me thank to both of our eminent speakers, Dr. KKR sir and Dr. Madhusudhanan sir. It was a very nice talk and a very nice knowledge sharing platform. They have used it and it was a betterment for our all the referrals. So I'm very thankful for the management for providing this opportunity to share this knowledge in this platform, and I hope it will be very useful for all the people who have attended. And even though if you have any questions, you can put in the chat box, or you may mail it directly to the email IDs provided, so that our expert can come back to you on it and they can give their opinions or the answers to your questions. So I would like to also add that all these IHC markers facilities is available at our laboratory, and we are dealing with more than 75 IHC markers in our laboratory for the histopathology and for the appropriate precision diagnosis. So kindly use these facilities, and the samples you can send to any of our collection centers. We have almost 10 collection centers across South Tamilnadu, and you can share or you can send the referrals to our samples. So that's it. And thanks for attending this session for all the participants. Thank you.